Okay, guys. So, chapter 17, pediatric emergencies. There is a whole lot here that we need to go over. Sorry, trying to go. Um, yeah. Anyway, whole lot to go over here. If I can get my computer to work. Here we go. So, pediatrics are a little bit different ballgame from adults. Um, age-related assessment findings and age-related assessments and treatment modifications for pediatrics specific major diseases and or emergencies. So the major ones are the upper airway obstructions, lower airway reactivity diseases, respiratory distress, failure, arrest. So a lot of your cardiac issues in pediatrics begin with respiratory issues. If our respiratory um, drive isn't working, or we have an infection or an obstruction, anything that has to do with affecting our respiratory in pediatrics will lead to a cardiac and then cardiac arrest if we don't treat it quickly. So pediatrics are a little bit different as far as assessment goes. On these, we're going to talk about how to use parents, how to use caregivers, and we want to definitely get that rapport or that trust built with that pediatric patient. So we definitely got to watch for things like shock, seizures, sudden infant death syndrome or SIDS, uh, patients with special challenges to recognize and report abuse and neglect. We're going to talk a little bit about that also. So respiratory and a pediatric, the anatomy, signs and symptoms and management of respiratory emergencies, and that's going to be the upper and lower airway and the differences in the anatomical differences adult to pediatric. Trauma, use simple knowledge to recognize and manage life threats based on assessment findings for the actually injured patient while awaiting additional emergency medical response. So the way this book's set up, if you guys haven't caught on yet, is you respond without an ambulance. You're a first responder, so you respond in a personal vehicle or you respond on a fire truck or something like that, law enforcement. This is without an ambulance in most cases, the way this book's written. Um, so you have to remember your equipment is limited. If you have it, great. If you don't, we're going to figure it out. So special conditions in trauma. So recognition and management of trauma in pregnant patient, pediatric patient, geriatric patient. Anatomy and physiology. So use simple knowledge of anatomy and function of the upper airway, the heart, the vessels, lungs, blood, skin, muscle, bones. Foundation of emergency care. See, so sudden illness and medical emergencies are common in children and infants. Anatomic differences exist between adults and children. Respiratory care for a child is extremely important. That's kind of why I pushed in the very beginning about cardiac and respiratory and cardiac. They're one and the same. They're brother, sister. Um, managing a pediatric emergency can be one of the most stressful situations you face as an EMR. You must remain calm and professional. Unless you are prepared, your anxiety and fear may interfere with your ability to deliver proper care. I can tell you firsthand that pediatrics are the toughest. They are the hardest. They will make or break you. Um, Reach it. I think almost every video, it's not your emergency, but when you have a child in front of you, it feels like it is. This is where, like I've said before, we're going to take that step back, do your job. Break down later, break down afterwards, go see a counselor, whatever you need to do. But during that emergency, our job is to take care of this child. That's really hard to do. Um, Parents can be either allies or potential problems. So talk to both the parent and the child as much as possible. Try to develop that rapport, that friendship with the child, earn their trust, squat, kneel, or sit down to establish eye contact, ask simple questions about pain. These are little kids. They're going to react different than an adult. Me personally, what I like to do is I will talk to the child. I make eye contact. I talk to the child, but every once in a while I'll glance up at mom or dad and make sure that they are following. Or if they have questions, I give them that chance. If the kid has questions, I give them a chance. Um, if you allow that child to feel like they're in control of the situation, sometimes that will actually calm them down. So be honest with the child. Some agencies provide a child with a trauma teddy bear to hold while being examined. I know the service I work for, we keep stuffed animals on the truck. Let them use your stethoscope. Let them play with the pulse ox. Explain to them that blood pressure cuff's going to give their arm a hug. Um, we've got to earn their respect. We've got to earn their trust before they let us do anything. So calm, quiet voices, talk to the child, make sure mom and dad are on board, make sure mom and dad understand. I don't want to say the severity of the situation, but if it is a severe situation, mom and dad need to understand it. We don't talk to parents or children in medical terminology. We break it down to its finest, easiest to understand. Um, Even if we need to draw a picture, we can do that to help that kid understand what we're doing. So the differences between a child and an adult. Um, a child's airway is smaller in relation to the rest of the body compared to an adult's. The child's tongue is proportionally larger than adults. So by head size, the tongue is a lot larger. And you can see over here in this picture, um, right here, this whole section is considered the tongue. And if you'll look at that compared to this is elongated. Your tongue up here has a better chance of falling back, blocking that airway. This does, it will, but in a child, it's a lot more likely because of its size. Um, a child's upper airway is more flexible than an adult's. For at least the first 6 months of their life, infants can breathe only through their noses. When demands on a child's respiratory system changes, the child is able to quickly compensate by increasing their breathing efforts. Infants and children have limited ability to compensate for changes in temperature as compared to adults. They're not going to be able to warm or cool as fast as we can. Um, with that being said, and I think it talks about it later, but if a child in shock, you're going to have an adult, and this is why we do our assessments every 5 minutes, every 10 minutes, whatever. Because an adult, you can watch go downhill. You can watch their vitals change. You can watch their skin change. You can watch everything change as they go into shock and they decompensate. A child is going to hang on, hang on, hang on, and then they just drop off. You're not going to have that long period of waiting and that long period of watching it slowly go down. You're just going to be cruising along good and then it's just going to drop off. They don't maintain like an adult does. So, examining that child, you're going to use the same or following 5 steps as an adult for that patient assessment sequence. So, performing extreme size up. Is it safe? Do I have my gloves on? Do I need help? How many patients do I have? Do I need C spine? Complete your primary survey. So, are my ABCs good? A, B, C, airway, breathing, circulation. Complete a secondary assessment by examining the child head to toe. Obtain that medical history. Usually, a caregiver or parent is best for this, but ask the kid. Let mom and dad answer if they need to. Perform a reassessment as needed. So when we are done assessing, we reassess. Um, so remember that our primary assessment, we take care of life threats at this point. Our secondary assessment, we take care of secondary injuries. These are broken bones, scratches, abrasions, stuff like that, non-life threatening. So the pediatric triangle or the PAT, It helps you quickly form a general impression of a child using only your senses of sight and hearing. It can be used to assess a child from a distance. So we all know what a little kid's supposed to look like. We know their color's supposed to be pink, warm, and dry. We know that most of them have high energy. We know that when a stranger walks in the room, they lock eyes on us and they're scared. Um, so when we walk in the room, we can immediately look at that child. If they're sitting on the floor, they're sitting in a chair, are they having to work to breathe? Is their appearance good? Are they pale? Are they red? Are they pink? Um, does it look like they're struggling in any way? And then as we approach them, can we audibly hear them breathing? Can we audibly hear anything? Uh, so all of this is done in that 3 to 5 seconds. We walk in the door, we lock eyes with this kid. Are they watching us? Are they normal for that age of child? And yes, there are stipulations. This is where parents or caregivers, we can be like, okay, what's normal for this child? Um, but we use that periodic pediatric triangle. We look at their appearance, we look at their work of breathing, and we look at circulation of the skin, which is what color are they? Are they sweaty? Are they clammy? Are they cold? I mean, um, it's just what we see and what we hear. So appearance, indicator of how well the heart, lungs, and central nervous system are working. Are we circulating oxygen through our blood, which is circulating? Um, Their child's appearance with what you would expect a healthy child to be. Assess the eye contact, which we talked about, muscle tone and skin color. Reassess regularly because appearance can change quickly, and that's kind of what I was talking about. An adult will hang or will steadily go downhill, and we can watch them change. Where a child is going to hold on, and then they just drop off. We don't have a whole lot of change there. Um, so characteristics of appearance, and I'm not going to read all this. You guys can pause the video and go over this, but the characteristics, movement, interaction, reassurance, eye movement, speech, and cry. We all know kind of what a child should be like. If it's not what it should be, we got to figure out why. So abnormal breath sound, abnormal positioning, retractions, and flaring of the nostrils. So that retractions, that's going to be above the collarbone between the ribs or depression of the sternum. This is where when they take that breath, everything sinks in. Um, Noisy breathing, snoring, crowing, grunting, or wheezing, that's not normal. Those type of things are what we need to be paying attention to. Abnormal positioning, so leaning forward while using the arms for support. That's called the tripod position. I think we talked about that in previous chapters. So that's when they're leaning forward with their arms down on their knees or on their legs, kind of supporting them, and they're sitting there huffing and puffing. Um, so work of breathing is a more accurate indicator of a child's condition than merely determining respiratory rate. If they're struggling to take a breath or they're making funny noises when they breathe, that is a big uh-oh. We need to help this kid. Um, so assessing that skin, so we're paler. That's pale. Modeling, that's that patchy skin, discolorization caused by too much or too little blood flow to the skin. We just got blotches. They'll be kind of a red purple color or even darker. And then cyanosis, that's that blue coloration of the skin. We're going to see that around the lips and the fingernail beds mostly. That's lack of oxygen. So respirations, count respirations for 30 seconds and multiply by 2. Um, Look for signs of respiratory distress. So assess how much work a child is doing to breathe. Look for abnormal breath sounds, such as noisy breathing, so snoring, crowing, grunting, or wheezing. And if you don't hear this just audibly with without anything. Explain to them what the stethoscope is, let them try it, and then use a stethoscope to listen to the alarm sounds. Look for signs of respiratory distress, so determine whether a child is holding himself or herself in an abnormal position. Check for retractions of the neck and chest. Look for flaring of the nostrils. So normal pulse rate of a child is faster than adult normal rate. For a child younger than 1, palpate the brachial pulse, which right here in this picture it shows that's what they're doing right there. Sometimes you kind of have to hunt for it. Go ahead and pause. Take a screenshot of this with your phone or write it down in your notes. You don't have to have these like by heart, but you need to have a really good idea. So a newborn heart rate is 90 to 180. Infant is 100 to 160. Toddler 90 to 150. Preschool is 80 to 140. School age 70 to 120, and adolescent 60 to 100. And then your respiratory rates 30 to 60, 25 to 50, 20 to 30, 20 to 25, 15 to 20, or an adult is going to be 12 to 20. Okay, make sure I didn't skip one there. High blood or high body temperature. This can lead to febrile seizures. So high temperatures are accompanied by flushed red skin, sweating, restlessness. To feel high temperature, touch the child's chest and head. Use the back of your hand to do that. To feel high temperature, oh, sorry, I read that. A child's heart rate increases with each degree of temperature. The temperature rises. So the higher the temperature, the more the heart rate goes up. If the heart rate's going up, our blood pressure's going up, our respiratory drive is going to have to adjust for that. So like I said, cardiac will lead to respiratory will lead to cardiac. It is important to open and maintain airway and to ventilate adequately any child with respiratory problems. Causes of cardiopulmonary arrest in children: suffocation caused by aspiration of the foreign body, so choking, infection of the airways such as croup or epiglottitis, SIDS, sudden infant death syndrome, accidental poisoning, or injuries around the head or neck. So opening the airway is a lot like an adult. You use the head tilt chin lift maneuver on children who have not sustained injuries to the neck or head. Do not hyperextend a child's neck when you tilt the head back. And the reason why is that airway is a lot smaller and it's not as defined or as firm. And you can actually, as you crimp the head back, it can actually close it off. Or if you push it too far forward, you can collapse it. So infants, they say use like a towel or a rag and just fold it a couple times and put it under the shoulder blades, and it will put that head in a neutral position. Trying to think here. If there's a possibility of the head or neck injury, we use that jaw thrust maneuver. Basic life support. So CPR for children is different from a CPR for adults. If you're alone and emergency medical services EMS has not been called, perform 5 cycles, 2 minutes of CPR before activating EMS. Use the heel of one hand or 2 hands to perform chest compressions. Compress sternum at least 1/3 the depth of the chest. So with children, it's 1/3 the depth. And most children, I know that varies, one hand is sufficient enough. You're just going to have to, if you perform CPR, you will learn how to feel what's correct. It's still the same compression rate to 2 breaths. CPR for infants is different than CPR for adults. Check for responsiveness by tapping the infant's foot or gently shaking the shoulder. Check the brachial pulse. Use your middle and ring finger to compress sternum just below the nipple line. Compress sternum at least 1/3 the depth of the chest. Give gentle rescue breaths. So I had a coworker, and I'd never heard this before. She told me to give an infant a breath. The way I learned is just enough to get chest movement. And she said if you'll blow your cheeks up, that's it. That's all you're giving it is what you can hold in your cheeks. Um, so I think that's a really easy way, a really good way to remember that. Suctioning, so clear the airway initially by turning the patient on his or her side and use the gloved finger to scoop out a substance. Use suction to remove the rest of the foreign substance. Suctioning can be life-saving procedure. Procedure for suctioning is the same as for an adult with the following exceptions. So use a tonsil tip or a rigid tip suction device. Use a flexible suction catheter um, to the nose of a child. Use a bulb syringe if you need to on infants. Never suction more than 5 seconds. And try to ventilate and reoxygenate patient before repeating suction. With that being said, so you never suction more than 15 seconds for an adult, no more than 10 seconds for a child, and no more than 5 seconds for an infant. Uh, with that being said, if you suction and it's still full of junk, we can't give that breath. We pull out, clean your suction tube, resuction. We can't just start bagging or giving breaths and pushing stuff into the lungs. Airway adjuncts, so oral airways can maintain an open airway after you have opened the patient's airway manually. Your book 17.1, How to Insert It into a Child or Infant. EMRs rarely use nasal airways for children. So a lot of times, I don't know why it said that. So a lot of times a child is more likely to accept a MPA over an OPA or a nasal airway adjunct. Place child on his or her back, tilt head, and lift chin in usual manner. Remove objects if it is clearly visible in the mouth and it can be removed easily. If not, do not attempt to remove object as long as the child can still breathe. Child should be transported to emergency department. Administer oxygen if it is available and you are trained to do so. Place oxygen mask over child's mouth and nose. Do not try to get an airtight seal. Hold mask 1 to 2 inches away from the child's face if they won't accept the mask. And that's called blow by. So we'll try a mask. If they won't accept it, then we hold it like right here and we blow that oxygen by as they breathe. They're getting something more than they were. This is another good example of where mom or dad or caregiver might come in handy because they can actually hold that while you continue to do what you need to do. Severe airway obstructions is a serious emergency. This is when there is absolutely no chance that they are moving air. You're probably starting to see cyanosis. So poor air exchange, increased breathing difficulties, might have a slight cough, I doubt it. Inability to speak and no air movement. Use the Heimlich or the abdominal thrust on these bigger kids. If they can stand and walk on their own and communicate, use the Heimlich maneuver or abdominal thrust. It provides enough energy to expel most foreign objects. Relieving an airway obstruction in a child is the same as an adult with a few exceptions. When opening the child's airway, tilt the head back just past neutral position. If you are not, or if you are by yourself, perform CPR for 5 cycles before activating EMS system. Those complete airway obstructions, an infant is very fragile. If you suspect an airway obstruction, assess the infant and determine whether any air exchange is occurring. If infant is crying, airway is not completely obstructed. If they're making noises and they're moving any air at all, it's a partial obstruction. If no air is moving in or out of that infant's mouth or nose, suspect a full obstruction or a severe airway obstruction. And this is when we're going to do a combination of back slaps and abdominal or chest thrusts, compressions. Assess the infant's airway and breathing. Place the infant face down, position over your one arm, and deliver 5 back slaps between the shoulder blades. So we want to, so you see how his hand's positioned here. He's not covering the mouth or nose. We want that child at a downward angle a little bit. We want gravity to help us. And as terrible as this sounds, we are not here to make a friend. We are going to deliver pretty good little blows to that child between the shoulder blades. And we're not trying to break their back or anything like that, but we need to cause enough internal pressure to expel that object. As soon as that happens, if nothing comes out, we're going to just simply, we've got that kid. So there's my computer here. We've got that kid here. We do our back slaps, place our hand on the back of the head, arm is along the body, and we just rotate them. And now I'm going to give 5 chest compressions. Flip them back over, and we can do back slaps, flip them back over, and do chest compression. And we're going to continue this until one, the child becomes completely unconscious, and then we're going to start CPR, or until the object's expelled. So if they become unresponsive, make sure EMS has been called. Begin CPR with chest compression. Continue CPR until person with more advanced EMS skills arrive. If small round objects do not become airway obstructions, they usually pass eventually through that child when they have a BM or bowel movement. Sharp or straight objects are dangerous if swallowed. Arrange for prompt transport. These can cut, these can get lodged, these can puncture, cause all kinds of problems. Sign of respiratory distress. So a breathing rate of more than 60 breaths per minute in an infant. Breathing rate of more than 30 to 40 breaths per minute in a child. We are going to see those nasal flarings on each breath, retractions of skin between the ribs and around the neck muscles, and stridor. If you don't know your lung sound, get on YouTube, go listen to lung sounds. Signs of respiratory distress. So we're going to find that cyanosis of the skin, so bluing of the skin, altered mental status, combativeness or restlessness. The treatment for respiratory distress is try to determine the cause, support the child's respirations by placing the child in a comfortable position, usually sitting. Keep the child as calm as possible by letting the parents hold the child if it's practical. Prepare to administer oxygen if it is available, and you are trained to do so. Follow your local protocols. Monitor the child's vital signs and arrange for prompt transport. Once again, we should be checking those vital signs nonstop in a child. Often results as respiratory distress precedes signs and symptoms. So the breathing rate will go fewer than 20 in an infant. Breath rate rates fewer than 10 in a child. Limp muscle tone. This child is going limp on us. They're turning into a rag doll. This is respiratory failure or arrest. They become unresponsive, decrease or absent heart rate, weak or absent distal pulses. A child in respiratory failure is on the verge of experiencing respiratory and cardiac arrest. Can't stress that enough. Child in respiratory trouble will go into cardiac arrest. Support respirations by performing mouth-to-mask ventilations. Administer oxygen if it's available. Begin chest compressions if the heart rate is absent or less than 60 beats per minute. Arrange for prompt transport. So I know that right there sounds really weird, and it's hard to kind of understand. Um, it's always kind of confused me a little bit, but that is not sufficient, um, not sufficiently cycling oxygen and blood through the body at 60 beats per minute for an infant. Um, so we start compressions so we can get that back up to that 100, 120 that we're supposed to be at. Circulatory failure. So, most common cause of circulatory failure in a child is respiratory failure. Can lead to cardiac arrest, indicated by an increased heart rate, pale or bluish skin, and change in mental status. If the heart rate is more than 60 beats per minute, complete patient assessment sequence, support ventilations if need be, administer oxygen, observe vital signs. If the heart rate is less than 60 beats per minute, begin chest compressions and rescue breaths. Altered mental status, so causes of altered mental status in children, low blood sugar. Um, yes, kids can have low blood sugar. Poisonings, um, post seizure state, infection, head trauma, decreased oxygen levels. Complete your patient assessment. Pay particular attention to the patient's initial vital signs. So these are your baseline vital signs. This is what we're going to base everything on from here on out. Our very first set of vitals, if they go down, we know we're getting in trouble. If they stay stable or they go up too stable, we know we're doing something right. Calm the patient and the patient's family. That's a big one right there. Because sometimes taking care of mom and dad is just as difficult as taking care of that child. Be prepared to support patients' ABCs if necessary. Place unconscious patients who have a pulse and are breathing in the recovery position. Because infant breath or breathes primarily through their nose, even a minor cold can cause breathing difficulties. Asthma is another problem in children, so caused by a spasm or constriction and inflammation of the small airways in the lungs. Usually produces a wheezing sound, so it's that whistle, that high pitched sound. Calm and reassure the parents and the child. The more you know, the more you can educate, the more you can help this person and the family. So, with asthma, place a child in a sitting position. First, lip breathing relieves some internal lung pressure, and that's what that kid right there is doing. Help administer the child's medication and arrange for prompt transport. Um, what that does is it changes the internal pressure inside the lungs when they do that pursed breathing. Croup. This is infection of the upper airway, and it occurs mainly in children between 6 months and 6 years of age. Results in a hoarse, whooping noise during inhalation and a seal-like barking cough. So if you'll remember that, right here, that will help you quickly determine or answer test questions. That croup is probably what you're looking at. It often occurs in colder climates. A lack of fright and willingness to lie down or important signs that distinguish croup from epiglottitis. If the EMS unit is delayed, turn on hot water in the shower and close the bathroom door. Moist, warm air relaxes vocal cords. So first, you gotta know what your epiglottis is. So your epiglottis is that leafy thing in the back of your throat that will close and it keeps food and water and stuff from going down the wrong hole. So it's a leafy shaped flap in the back of your throat. So knowing what that is, epiglottitis, so titus is inflammation or swelling, so it's swelling of the epiglottis. Severe inflammation of the epiglottis flap is so inflamed and swollen that air movement into the trachea is completely blocked. So that flap has swollen up enough that it's actually blocking our trachea and we're not getting air movement. Usually occurs in children's between the ages of 3 and 6 who were not vaccinated against disease. Signs and symptoms: child is usually sitting upright. Child cannot swallow. Child is not coughing. Child is drooling. Child is anxious and frightened. Child's chin is thrust forward. Here is the big one to help you remember it. This is a big telltale sign of epiglottitis. Um, make child comfortable with as little handling as possible. Keep everyone calm, administer oxygen, and arrange for prompt transport. So drowning, caused by submersion in water and initially causes respiratory arrest. Second most common cause of accidental death among children 5 years of age and younger in the United States. Do not put yourself in danger as you attempt to rescue these people. If you're not trained in water rescue, don't do it. Really hard to accept. As a first responder, as someone who wants to be a hero and help people, you're no good if you're a floater too. My very first traumatic calls. I was still on my clinicals as an EMT, and I went on a drowning of a 17-year-old kid who couldn't swim, fell in deep water, and it was traumatic. He didn't have to die. So these can be very emotional and hard to deal with. Most of these, a lot of people don't realize, are actually dry drownings because you go underwater, your body will naturally have a reaction or reflex, whatever you want to call it. That epiglottis will close. So when you're sucking in water, it's actually going to your stomach. What happens is you suffocate from lack of oxygen, not because you fill up with water, but because you're closed off. So you actually drown because you're not breathing. After you have went limp, everything relaxes, and then you fill up with water. A lot of people don't realize that. Signs and symptoms include lack of breathing and no pulse. Treatment: we got to assess those ABCs. We open the airway. We start bagging these people, and we start CPR usually. Turn the child onto one side and allow water to drain out of the child's mouth. Use suction if it's available. Start rescue breaths if necessary. Administer supplemental oxygen. This is going to be one of them high flow, or we're bagging them with oxygen also. If no pulse is present, start chest compressions. Stabilize the neck as needed. So if this is a possible, like dove in and hit their head on the bottom type deal, or they're jumped off a hill into a pond or something, let's go ahead and stabilize that neck. To reduce the risk of hypothermia, dry the child and cover him or her with dry blankets. Arrange for prompt transport. Heat related. So heat stroke is a serious and potentially fatal condition that requires rapid treatment. So remove the child's clothing, sponge water over the child, and fan him or her. You may wrap the child in wet sheets to speed up the evaporation and cooling process. Arrange for prompt transport. On these, yes, we want to get the clothes off of them. We need to access their skin, let them start cooling. But a lot of times we can get them like good and wet. I love the wet sheet idea. Um, it will start cooling them. We can move them into a cool area. And we do need rapid transport on these guys. So high fevers. So fevers are common in children because temperature regulating mechanism in a young child has not fully developed. A very high temperature can occur quickly. Most children can tolerate temperatures as high as 104. Remember that as that temperature goes up, so does the heart rate. Uncovered child, so the body heat can escape. Attempt to reduce high temperatures by undressing that child. Fan child to cool him or her down. Protect the child during any seizure, and make certain that normal breathing resumes after each seizure. So these are those febrile seizures we was talking about. Child gets temperature goes up. Um, those seizures will come on due to how fast the temperature goes up internally. So if you go from like 100 to 105 in a matter of just minutes, um, you're probably going to get a febrile seizure. And the only treatment we've got for seizures is comfort. We protect their heads and we protect them from hurting themselves. So we move furniture out of the way, whatever we need to do, and we support their head. We don't try to stop the seizures. We talk to them because a lot of people having seizures can still hear you. Um, so we reassure them. We stay with them. We talk to them in a calm voice. And the second that seizure's over, we make sure that they continue to breathe on their own. And now we're going to go into seizures. That explained all that. Um, it can result from high fever or from disorders such as epilepsy. Um, they vary in intensity. During a seizure, child loses consciousness, eyes roll back, teeth become clenched, body shakes with jerking movements. They can still hear you a lot of the time. That's why I'm like really big on you get down there, you hold their head and you talk to them calmly. You tell them you're with them. You know they're scared, but it's going to be okay. Um, you stay with them. During a seizure, child's skin becomes pale or turns blue. Sometimes the child loses bladder or bowel control. So treatment: place patient on the floor or on a bed and prevent injuries. Maintain an adequate airway after seizure ends. We can supply oxygen if we've got it, arrange for prompt transport, monitor the patient's vital signs and support ABCs. After a seizure is over, cool the patient if he or her has a high fever. The other thing I'm going to tell you is try to time it. Um, Time how long the seizures last and roughly how long between each seizure there. Vomiting and diarrhea, so usually caused by gastrointestinal infections, may produce severe dehydration. Dehydrated children is lethargic and has very dry skin. Hospitalization may be required to replace fluids. If you suspect dehydration, arrange for transport. Um, Once again, this kid's not acting like a kid. Um, you can do the whole pinch the arm thing, which you just pinch, pull up, and let go. If it stays there, it's called tenting, and that means dehydration. Abdominal pain. So one of the most serious causes of abdominal pain in children is appendicitis, seen in people between 10 and 25. Usually, children in nausea is nauseated, has no appetite, and occasionally will vomit. Treat every child with a sore or tender abdomen as an emergency. Arrange for prompt transport. Keep these children comfortable. Keep them calm. Don't be surprised if they vomit. Remember that these are kids and they are going to stress out on you. Try to coach them in breathing if you need to. Keep them calm. Ingestion, an ingested poison. So we're on poisoning now. Sorry. An ingested poison is taken by the mouth. So we ingest it. So it's by the mouth. Signs and symptoms: chemical burns, odors, and stains around that mouth, nausea, vomiting, abdominal pain, or diarrhea. These are all very possible. I will add to that because I've had one of these. Um, Mom or dad will be losing their stuff. You're going to treat mom and dad as much as you treat the child on this one. Follow your local protocols. Most protocols are going to tell you to call poison control. Um, Lighter symptoms: abnormal or decreased respirations, unconsciousness, and possible seizures. Try to identify the poison and send container to emergency department. Gather any spilled tablets and replace them in a bottle so they can be counted. Um, yeah. Contact your local poison control center if transportation is delayed. Like I said, follow your local protocols because most of them are going to tell you to call poison control anyway. You may need to give the child large amounts of water or administer activated charcoal. Uh, check your protocols. Monitor child's breathing and pulse. Arrange for prompt transport. So absorption, this occurs when a poisonous substance enters the body through the skin. It absorbs into your skin. Localized symptoms include skin irritation or burning. Systematic signs and symptoms include nausea, vomiting, dizziness, and or shock. Ensure the child is no longer in contact with that poison substance. If it's a powder, let's wipe it off and then rinse it. If it's something besides a powder, you know, we need to try to make sure that we can get it removed, but don't like get it on you. Protect yourself from exposure. Remove the child's clothing if it is contaminated. Brush off dry chemicals, and then wash for 20 minutes. Try to identify the poison. Usually, a caregiver's around who can help do that. Monitor child for any changes in respiratory and pulse. If the child has vomited, save a sample and send it to the hospital. Arrange for transport. Okay, so SIDS or sudden infant death syndrome. Um, it's also called crib death, sudden and unexpected death of an apparently healthy infant. This usually occurs in infants between the ages of 3 weeks and 7 months. No adequate scientific explanation for SIDS. We don't know what causes it. Be compassionate with parents. These parents have taken a healthy baby home. They usually have those few couple 3 weeks or more, and all of a sudden their kid's gone. This is going to be very, very difficult. We have got to be compassionate. We've got to, we can't educate on this because we don't know. You don't know, I don't know. Nobody knows what causes it. This is where we can offer to call family. We can offer to call a preacher, a priest. We are just there as support givers at this point. If an infant is still warm, begin CPR and continue until help arrives. If an infant is dead, do not mistake large bruise-like blotches on the body of signs of child abuse. We never just assume that. Blotches are caused by pooling of infant's blood after death. Follow local protocols and management of deceased patient. This is where we are going to call our medical director. We're going to do online medical direction. We're going to tell them what we have, and we're going to have to tell the parents. And I can tell you once again from personal, this is very, very difficult. So take care of yourself afterwards. Pediatric trauma is the number one killer in children. So treat an injured child as you would treat an injured adult, but remember, follow the differences. Children cannot communicate symptoms as well as adults. Children may be shy and overwhelmed by adult rescuers. Treat the injured child as you would an adult. Okay. You may need to adapt materials and equipment to the child's size. A child does not show signs of shock as early as an adult, but can progress into severe shock quickly. That's what I've been telling you guys. Won't show any signs and then they go down. The other thing I want to throw in here real quick, I know assessment is basically the same when you do a traumatic assessment on a child, except if you can, start at the feet and work to the head instead of head to feet like an adult. You go at a child's head first and they don't know you and they are awake, they're going to freak out on you. If you start down at the feet and you talk to them and you work your way up and you're staying calm, you can get away with that a lot easier. Patterns of injury sustained by children will be related to three factors. So types of trauma they experience, type of activities causing the injury, and child anatomy. So motor vehicle crashes, unrestrained patients have more head and neck injuries. Restrained patients often suffer head, spinal, and abdomen. Restrained patients often suffer from head, spinal, and abdominal injuries. So like bicycle accidents, this is very possible. Children often suffer head, spinal, abdominal, and extremity injuries. The use of a bicycle helmet can greatly reduce the number of severities of the head injury. So children hit by cars often sustain chest, abdominal, thigh, and extremity injuries. Fall from a height or a diving accident causes head, spinal, and extremity injuries. Burns are a major cause of injuries in children. So I want you to look at this picture over here. Compare this to an adult. If an adult's hit, we're going to be going like from hip down, right? So if we hit a child, look at where the child's being hit right here. There's a huge difference there. One, he's going to fly down and hit his head like here, or two, he's going to go right underneath this car. So pedestrian versus car, we've got to look at the size of the vehicle versus the size of the patient. And that's going to give us a better mechanism of injury. When we look at it that way. Sports injuries cause a wide variety of injury depending on the type of sport activity. Treatment, regardless of cause of injury. So we always check ABCs. We stop severe bleeding because that's a life threat. We treat the patient for shock because that's a life threat. Conduct a full body secondary assessment. Stabilize all injuries you find. So we take care of life threats. Then we do our secondary. We take care of secondary injuries. If the patient has head lacerations, treat wounds with direct pressure and bandaging. If it's a head injury, do not do a pressure wrap. You can put a gauze on it. You can use just regular bandage to wrap it and hold it in place, but don't do compression. Let's see. Traumatic shock in children. So children show shock symptoms much more slowly than adults do, but the progress through stages of shock quickly. If signs of shock are present, child is already in severe shock. So we're going to be doing really good. You're going to turn around and look at this kid, and they're going to be cool, pale, and clammy. Pale, cool, and clammy. They're going to have a rapid and weak pulse, and they're going to have rapid or shallow respirations. They are going to go from doing good to nothing. Seizures are relatively common in children who have sustained a serious head injury. The greatest dangers are airway obstruction and hemorrhage. So we want to open and maintain that open airway. We want to control bleeding, and we want to arrange for a prompt transport. If you find a child properly restrained in a car seat after a motor vehicle crash, leave the child in the car seat until an ambulance arrives. In some cases, a child can be transported to the hospital secured in that car seat. And sometimes that's the safest bet. You see here that kid's not happy, but they're holding C-spine. They're trying to keep her calm. They're keeping her from kicking her feet, moving her spine all over the place. Sometimes these aren't fun, but they're doing exactly what they should. Be concerned if a child is withdrawn, fearful, or hostile. Sorry, talking about child abuse now. And is unwilling to discuss how injuries occurred, treat child's injuries, and if you suspect abuse, ensure child's safety. Signs and symptoms, multiple fractures, bruising in various stages of healing, human bites, burns, reports of bizarre accidents. If this kid's story makes absolutely no sense, and you've got bruises on the legs, arms, butt that are all in different phases of healing, or if the story that you receive from the parent does not add up when you look at these injuries, you can suspect it. Don't ever accuse a parent or straight up ask a child. We don't do that. So A here, it shows different stages of bruising. Right here, I'm not even sure. What does B say? Human bite wound has a characteristic pattern, so that's bite, that's teeth. This is called gloving. This is where a child has been put into hot water or their arm's been stuck in, and they will have a burn right up till the water stopped, and then it's normal. And it can be on the butt, it can be on the genitals, it can be on the legs, arms. That is, you can see right there is the line. This child was placed in hot water or something that deep because it goes from severe burn to nothing up here. That is gloving. So transport a child if parents object, summon law enforcement. Okay, cool. Walk outside and call PD. Tell them what you got. Signs and symptoms of neglect, so lack of adult supervision, malnourished appearing child, so super scrawny and just not healthy for that age, unsafe living environment, and untreated chronic illnesses. Sexual assault of children. In addition to experiencing sexual assault, children may have been beaten and may have other serious injuries. Obtain as much information from the child and any witness. Provide a caring approach. All victims of sexual assault should receive transport to appropriate medical facility. I'm going to throw one more thing in there. If you believe this is a sexual assault patient, call PD. Get law enforcement involved. Go back and write up an incident report. Get a hold of your director or your supervisor and do an incident report. Calls involving children tend to produce strong emotional reactions. You may need to talk about feelings and anger and frustration with a counselor. Be attending briefing sessions that you can. And you also need to express your feelings, learn some coping strategies, maintain a healthy approach to future calls. I am really big on this one because I've had some really bad calls for my area. So the mental side of EMS, I really, really harp on this. Men or women, I don't care. Express your feelings. Go to a counselor. Go to your supervisor. Be honest. Talk about what you're feeling, about what you're thinking. Learn some coping strategies, and that doesn't mean go out drinking every day off. Some people like camping, hiking. I play golf and hunt, and camp. Some people jog. Find something that when you do it, you don't think about work. Find something that you can do that takes up your time and clears your mind. Maintain a healthy approach to future calls. These things are terrible. Do your job, do it right, and you can wake up the next day knowing you did all you could. You're always going to question yourself. I don't care how good you are. But just know on that next call, you're going to be even better. Medical is called a practice for a reason because it's never the same. Every time those tones drop, we learn something new. So don't beat yourself up over stuff. We're not going to sit here and go through the summary. So the purpose of a pediatric assessment triangle, or a PAT, is to guide the hands-on physical assessment, help you determine if a child's vital signs are appropriate, allow you to quickly form a general impression of that child, help you remember systematic assessment processes. So remember this, the pediatric triangle is what we do as we walk in the room. We look at that child. Are they looking at us? We are forming a general impression before we even get to the child. So the answer is C. It allows you to quickly form that general impression. Which of the following statements about SIDS is false? It usually occurs in children 3 to 7. No adequate scientific explanation exists. It occurs in appropriate, healthy children. You should start CPR if the children or child is still warm when you arrive. So once again, here's one of them trick words. It's false. Last time it was accept. This one is false. Look for these words. So we know that in SIDS, there is no scientific explanation. We know that it does occur in healthy children, and that if that child's still warm when we arrive, we better do CPR, right? So it's the 3 to 7, because this happens in, what was it, 3 weeks to 6 months or something. So A is the correct answer. Which of the following is not a common respiratory condition in children? We know children have asthma. We know epiglottitis happens in children. We know that croup, that sill-like bark, okay, We know epiglottitis, remember the drooling? That was our keyword. So the one that's not there is pneumonia. Answer is C. So I hope you guys got something out of this one. That's pediatric emergencies, and I will catch you on the next one.